Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on considering novel therapies for HIV, featuring Cristina Mussini, head of the Department of Infectious Diseases and Tropical Medicine, and full professor of infectious diseases at Infectious Diseases Clinics at University Hospital, University of Modena and Reggio Emilia in Modena, Italy. And William Short, Associate Professor of Medicine in the Division of Infectious Diseases, Department of Medicine at the Perelman School of Medicine at the University of Pennsylvania in Philadelphia, Pennsylvania. They'll discuss novel therapies for HIV prevention and treatment, and following their dialogue, the faculty will field questions from healthcare professionals. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Drs. Mussini and Short.
Thank you, Jessica. So in this first slide, we have the summary of PrEP eligibility by regimen. You see that we have different recommendations on the basis of the different population at risk that we are considering. The only one that is for now in Europe available for all persons at risk is the daily tenofovir diproxyl fumarate FTC. It is also FDA approved and recommended by all guidelines, including EACS guidelines. And it's available for MSM, transgender women, heterosexual men, heterosexual women, and transgender men. For TAF, considering this is the daily drug, if we consider the on-demand tenofovir diproxyl fumarate on the basis of the hypergay study, only MSM could be treated with PrEP with this schedule on demand. And it's recommended in Europe, since it was also a European study conducted in France, but also it is off-label but recommended by ISS, USA, and WHO guidelines. As I said, no data, we have no data for the other population at risk. On the basis of the DISCOVER trial, TAF, FTC are recommended for MSM, transgender women, heterosexual men, while it is off-label and not recommended for heterosexual women and transgender men. Long-acting Cabotegravir is not actually recommended in Europe because it has not been registered by EMA, but while in the States it is recommended because it has been studied, as we will see, in all the population at risk, so it is recommended for all the population, but in the US. Considering the dapivir ring, vaginal ring, it is unavailable in the US, it is unavailable in Europe, but EMA gave a positive option only in high burden settings, and it's WHO recommended. So we talk about the novel PrEP strategies, and the most recent is for sure the injectable Cabotegravir 1. The recommendation by FDA has been made on the basis of two studies, one phase 2B, phase 3, that is the HPTN 083, and the other one is a phase 3, that is the 084 trial. These two trials were very similar. They were pretty the same. They only enroll different population at risk. The 083 enroll MSM and transgender women, while the 084 cisgender women. And they both the comparator was tenofovir FTC daily PrEP, and it was a placebo-controlled trial. The trial duration of the long-acting was 3 years, and after 3 years, all patients enrolled received for 1 year for free tenofovir diproxyl fumarate FTC every day as PrEP. So the efficacy, as you can see, both studies reached superiority of Cabotegravir, and the number of events in Cabotegravir in the 083 was 13, while in the comparator was 39, with a protection of 66% of Cabotegravir, while in the 084, it was 4 in the Cabotegravir arm. I remember that this study was conducted in cisgender women, a population that has always been difficult to treat with PrEP and where the results were really not very good. So 4 in the Cabotegravir arm and 36 in the tenofovir FTC arm with a protection that was 89%. But let's have a look at the infection that they were found in the 083. As you can see, really the population that was enrolled was a population really at risk, because 4 people already had the infection at baseline. So before starting the trial, even if they got the results after the starting of the trial. 5 infections happened after a prolonged delay in Cabotegravir dosing. So you know that the window is 2 months with a tolerance of another week or 2. But if you prolong this period, you could be without protection, and this happened in 5 of them. While 3 infections happened during the oral lead-in in both arms, because also Cabotegravir for the first 5 weeks was at an oral lead-in, while you know now that FDA said that the oral lead-in, could be skipped. While the last 4 infection happened in the 083, despite a perfect dosing of Cabotegravir. So after 1 year of unblinding, we see that there were a few new infections, 13 additional infections on Cabotegravir. 2 were newly identified Cabotegravir infection during the blinded period. As I will tell you, there has been a latency in the diagnosis, and both of them were on time. So there were 4 before and 2 now. So we are talking about 6 infections in the 083, infection in patients who really were on time in their Cabotegravir dosing, while 11 were during the unblinded period, 1 with one-time injection and 3 with delayed injection, and 7 with more than 6 months after Cabotegravir. So to date, among 2,244 participants randomized to long-acting Cabotegravir, there were 7 breakthrough infections on Cabotegravir despite on-time dosing. And this is the 084, and you see that there was 1 infection at baseline. We were talking about 4 infections. 1 was at baseline, 2 were in the absence of long-acting Cabotegravir injection, and 1 was in a patient that had a delay. So in the 084, there were no major INSTI mutation in the Cabotegravir arm, but the problem was the delay in the diagnosis. So we are starting to think, all the experts are starting to think that probably in patients who are on PrEP, and there were a few questions yesterday on this topic, in those patients, maybe HIV RNA would be a better diagnostic tool. So when we talk about monitoring and safety in people undergoing long-acting Cabotegravir for PrEP, in HPTN 083, HIV detection with antigen antibody testing was delayed compared with qualitative HIV RNA testing, exactly as I said before. So the delay was very long because Cabotegravir delays was 62 days for baseline infection and 98 days for incident infection. So very long. That's why the patients were exposed to drugs. And FTC TDF delays was 34 days for baseline infection and 31 days for incident infection. And again, also this. 7 participants in the trial received long-acting Cabotegravir after HIV infection. And this led to the development of 5 patients with INSTI resistance. And this will be important with the widespread use of long-acting Cabotegravir. We will face new naive patients with INSTI resistance at baseline, while now INSTI resistance is pretty rare. 2 were not tested because they had an HIV RNA below 500 copies at all visit. As I said, in most cases, it was determined that screening with an HIV RNA assay would have detected infection before a major INSTI-RAM or accumulation of additional major INSTI-RAMs. So it would be important for this. Considering injection site reaction, they were common. It's an injection, so it's normal to have injection site reaction, but the most important thing is that this rarely led to discontinuation. 0 in HPTN 084 and 2.4% in the 083. So I just want to hear Bill about his experience, because unfortunately we don't have long-acting PrEP in Europe for now. So I'm just looking for his suggestion. Yesterday, for example, we were talking about transgender women, and I think that with silicone, for example, I think that we are just understanding the best way to administer also this drug. So please, Bill.
Thank you. I think we are still working through our flow for this. We have much more experience with long-acting Cabotegravir rilpivirine, but we are now adjusting our flow to a similar thing where, we try to make sure we have a multidisciplinary team to sort of handle, all the different components of this. So, I have a little bit of experience with it, talking to patients. Some are interested, some are not. So it's still very interesting. I feel like the prevention side and therapeutic side are very, very different. For the prevention side, I find more are not wanting to go to injectable, which is interesting to me. But the ones we do have on it, they really like it. Again, I think the hardest part is getting into the flow in the clinic. And like you said, a lot of the hurdles that we had, we were able to work through when we dealt with the treatment form, the long-acting rilpivirine. So I think we sort of got through that. Now it's just a matter of making sure we get patients in. And I think the other piece that's really we're still scratching our head about is how to do testing. Do we do viral load testing on everybody? Looking at the PrEP guidelines, they're different. And, we actually had a really great presentation this morning looking at the PrEP guidelines and, how hard it is you're sort of making, these are healthy individuals coming in for prevention, and you're making these very complicated visits with screening for, it's very, very complicated. So we are still working through our difficulties, so to speak.
Yes. I remember to the audience that they can ask questions and we will see them. So if you are interested in any of the aspects that we are treating, we will have also time at the end for question and answer. So when we talk also about, there are different drugs that should be developed for PrEP, but actually both of them have been put on hold for different reasons. One is islatravir, that is in clinical development for treatment and prevention of HIV, multiple PrEP formulations that are very interesting because oral tablet is once monthly. As Bill was saying, maybe there are some people who are reluctant to receive injections, and once a month pill would be ideal for them, or even subdermal implant that is once yearly, potentially with contraceptive. So that would be very interesting, but the problem is that the islatravir PrEP program as islatravir treatment program have been placed on hold by FDA due to the observed decreases in total lymphocytes and CD4 cell counts in clinical trials. with other issues, but also Lenacapavir, that is an HIV capsid inhibitor that I will talk about in a few seconds, is in clinical development for treatment and prevention of HIV. Long-acting formulation, because it's a long-acting drug and it's a subcutaneous injection every 6 months. So it's really interesting about and challenging about this. But the problem is that now it has been put on hold due to concerns about compatibility between the drug and the borosilicate vials. So we will see I know that they are working in order to solve this problem, and I'm pretty confident that while for islatravir is more difficult, I think it will take a few more times than to find a new vials for Lenacapavir, I think. So when we talk about novel initial therapy, we don't have a lot, but it's, for me, that I'm in the field since 30 years ago, it's still fascinating that there are new drugs and new challenges and new projects and perspectives. So this idea of long-acting is very, very interesting. I know that Bill will talk about it much more in detail after me. But the only drug that I will talk about is Lenacapavir. They have conducted the CALIBRATE trial. As you see, it's not a large trial. We are talking about less than 200 subjects and very small groups. So we have 2 groups that until week 28 were treated, were receiving either Lenacapavir subcutaneously plus TAF-FTC. But once they got undetectable, they were switched to do a regimen, one with Lenacapavir plus TAF, and the other one with Lenacapavir plus Cabotegravir alone. While the 2 other arms were in triple therapy, one with Lenacapavir plus FTC TAF, both oral, so everyday treatment, and the same for oral Biktarvy. When we look at the results, the week 54 virologic outcome that were presented at CROI earlier this year, we see that there was not a huge difference between the arm, either in the intention to treat analysis or in the snapshot. It's important to underline that we are really treating our patient in a very good way, for example, with Biktarvy. So it's difficult for a new drug to be introduced in clinical practice with results that are better than a percentage of undetectability that is above 90%. So we will see. We are talking about very few patients. It's more a proof of concept than a real trial. It's possible that a dual combination is feasible, but obviously, talking about a long-acting, I don't know if using a long-acting and then a pill every day of a single drug or of 2 drugs, it's really innovative when we compare it with 3 drugs in 1 pill every day. And also, I have to agree with Chloe Orkin that during the CROI talk said that probably, and we will see also the data on the long-acting already available in treatment that Bill will present, it seems like this new long-acting drug don't have the same high genetic barrier that we are used to have with the new drugs that we are using. So most recent drugs that we are using. So it is not surprising that in the few patients that fail, some of them develop, even if it was in triple therapy with TAF-FTC, one subcutaneous and the other one oral, there was the development of resistance at failure. So there was incomplete adherence because, as I said, a schedule that is mixed is not so easy. And also having more pills, we know that usually led to a worse adherence than a single tablet regimen. It's important to know that both of these patients resuppress with a triple therapy with INSTI and 2 NRTIs. So it was well tolerated, but there was an injection site reaction, mostly of grade 1 and 2, one of grade 3. There were 3 discontinuations due to injection site reaction. So we have also to consider this. And with pleasure, I introduce Bill Short that will talk about novel switch strategies.
Great, thank you so much. So now we're going to switch gears and we're going to talk about switch strategies and really about novel switch strategies. As you know, if you're in practice, we do a lot of switching. There have been numerous studies involved in switching, not only within class, but between classes of drugs. So there really are studies, but this is going to be a different type of switch. And that's switching to a long-acting injectable, which was something new. And as we know, this was FDA approved a little over a year ago. So this is a follow-up. This was the Atlas 2M study, again, looking at that long-acting cabotegravir and rilpivirine. And this was comparing every 8 weeks versus 4 weeks. And again, to put this in context, when it received its initial approval, it was for an oral lead-in followed by every 4-week injections. And now this was looking in a subset in that Atlas 2M study of comparing Q8 week versus Q4 weeks. Just quickly walk you through the study design and then show you that this analysis we're going to talk about, which was presented at CROI, is focused on the week 152, which you see here in the study schema. So these were 2 populations. They were adults from both the Atlas trial, where they were receiving long-acting cabin and long-acting rilpivirine every 4 weeks, or standard of care ART, and patients receiving standard of care ART that were outside of Atlas. And you can see here they were stratified by prior exposure if they had been on cab and rilpivirine, to then get oral cab at 30 milligrams with rilpivirine 25 milligrams. And again, this was except the Atlas participants that were receiving the long-acting treatment already. That was for 4 weeks or 28 days. And then they were randomized into one of 2 arms. So it was basically long-acting cab with rilpivirine. And this was IM every 8 weeks. And then the other arm was the same thing, but it was every 4 weeks. And what you note that's difference between the 2 is the dosing. For the Q8 weeks, it's 600 a cab with 900 rilpivirine. And in the Q4, it's 400 and 600, which were obviously studied in the Atlas and FLAIR trials. So the primary endpoint we saw was that HIV viral load greater than 50 copies at week 48 by the FDA snapshot, and it was an intent to treat exposed population. That Q8 weeks was found to be non-inferior to Q4 weeks at week 48. And again, now we're going to look at the week 152 endpoints, and you see them all listed there. So we're going to look at plasma viral load. Remember, this is a suppressed population, so we want to see the percentage that were greater than or equal to 50 or less than 50 at week 152. Confirmed virologic failure incidence, viral resistance to those who met that definition of confirmed virologic failure, safety tolerability, and then treatment satisfaction, which we'll look at by patient-reported outcomes. So here we are. Here's the week 152 outcomes. Just as you can see, I mean, the lines here looking at virologic success, clear across, there really is nothing that stands out. And just so you have a sense of what this graph shows, if you look in the blue and red, which is the graphs to your left in the histogram, they are the intent to treat exposed population. And the ones to the right are the per protocol population that you saw. And again, clear across, you saw that there was no difference. There were 13 participants who had confirmed virologic failure. 11 were in the Q8 week, which was 2% of the population, and in Q4 week was 2 or less than 1%. And none had injection that were more than 7 days late. So it really was not about that. So these were not patients who came in late. And again, if you look here at those patients, so of those 11 in the Q8, 9 of them had rilpivirine RAMs, and then 8 had Insti RAMs. And in the Q4, you can see 1 had rilpivirine and 2 had Insti. As we talked about in other studies, and it's the same here, long-acting cabin rilpivirine was well tolerated. 99% of the injection site reactions that were seen were in that grade 1 and 2, so mild to moderate. And the median duration of symptoms was about 3 days. And then you can see here the percentage of patients. So it's around 2-3%, 2 in the Q8 week arm and 3 in the Q4 week that withdrew to injection site reaction. And patient satisfaction scores, as you might think, significantly favored Q8 versus Q4 week. And I can mirror this from our clinic when we've asked patients to almost none. I think we've had one say, I would absolutely rather come in every 4 weeks. So most people are really excited to move into the Q8-week dosing. This is something that is constantly asked. I know I get called all the time asking, what are the things we think about for failure? How will I know if this person's at risk for failure? And I always draw people to the package insert. And I think that's really important to look at what is the indication for long-acting cabotegravir. It's not someone who has multiple mutations, multi-drug resistant virus. It's very clear, and it's highlighted here. It's for those on a stable regimen, and it lists, what the recommendations are, how long you should be suppressed for, with no history of treatment failure and no known or suspected resistance to either one of the components. So to cabotegravir, the integrase, or rilpivirine, the NNRTI. So this was a post-hoc analysis, and again, I think this is very, very useful to use in clinic or when you're thinking about your patients and who would be associated for confirmed virologic failure. And this was a post-hoc analysis done on the week 48 phase 3 data. So Atlas and Flare at the Q4 week dosing, and then Atlas 2M, which was both Q4 and Q8 dosing. You can see about 1.25%, so 13 out of over 1,000 had confirmed virologic failure. And then you can see very large, about 97% with 0 or 1 risk factor for confirmed virologic failure, and 0.4% had confirmed virologic failure, which is, again, a small number. Q8-week dosing, and I think this is really important, was not a significant factor associated with confirmed virologic failure. And a lot of people have asked that, if I switch, is this really going to cause some problem? And this is not what was seen. What you look here and see is that there's 2 parts to this. So what were the factors that were associated in that multivariable analysis? And there were 4. So it was having rilpivirine resistance mutations at baseline. Again, you see all the odds ratios. The week 8 rilpivirine trough concentration, having baseline viral subtype of A6A1, and then BMI at baseline, so a 1 unit increase in BMI. These were the factors that were associated. But interesting enough, just having one of those was not enough. So you can see here, if you look at confirmed virologic failure, if you had none of the baseline factors, your confirmed virologic failure rate was about 0.4 and 95% chance of achieving a viral load less than 50 copies. Same thing with 1. But look what happens when you get above 2. That number bumps. So 26% had confirmed virologic failure. And again, you can see percentage getting to undetectable, which was 71%. The way I look at this is, not one specific factor was associated with confirmed virologic failure. It really was 2 or more. And then also the Q8-week dosing was not a factor that was associated with confirmed virologic failure. So I hope this slide is very helpful, and I think very useful for you in terms of clinic. The other thing that's really exciting, and I'll do a quick pause, is that, recently, as of March 2022, the oral lead-in is optional according to the FDA approval prescribing information. And what you see here, there was a direct-to-inject, so a switching to long-acting cabotegravir without an oral lead-in. This was the Flare extension study. And what you can see is that patients who were receiving the standard of care, so dolutegravir, bacteria 3-TC, would achieve viral suppression, defined as, as we see here, viral load less than 50 copies, that actually switched to monthly long-acting cabotegravir at week 100. And then you can either elect to start with or without. So fair balance, about 121 started with the oral lead-in, 111 started without. And what you see here, and I won't walk you through every single one, there was really no difference between the 2. So in terms of achieving viral load less than 50 copies, 99% that went direct to inject, and 93% in the oral lead-in. And again, very similar rates of virus load greater than 50, and then no virologic data down here. So really, really exciting, I think. A lot more options for patients now. We have the FDA approval of the Q8-week dosing, and as well as having an optional oral lead-in phase. I'll briefly talk about this for a second. As a reminder, when you have someone who is a pregnancy potential, so anyone who could get pregnant, remember when giving long-acting cabotegravir that these drugs can stay in your system for very long periods of time. And I will just briefly draw your attention to this. So these were patients who were enrolled in clinical trials associated with this combination. And per the clinical trial protocol, the injectable was discontinued. And in this case, it was all women were switched to alternative ART regimens. But it's important to know what were the outcomes of those pregnancies that we saw. So 26 pregnancies occur. And what you see here is the disposition of them. So there were 11 live births, 8 elective abortions, 7 spontaneous, 6 were in the first trimester, and 0 stillbirths. So you can see this. And again, this is really important. We need this data because I think the bottom line really is a punch you right in the stomach type of thing, that you should really walk away from this knowing that after discontinuing the injectables, so the person was getting long-acting cabotegravir, the concentrations of each were sampled for about 52 weeks after the last dose. So that is really important when you are planning and discussing and having conversations about maybe using this as a novel switch strategy. It's really important to let patients know that despite discontinuing the drug, based on this PK sampling, you still will have concentration sampled out long after you stop the injection. So this is really important to know. I'm going to stop. I know, Cristina, I learned yesterday you're not using this much in the clinic, and I'll just say
Not yet.
Not yet, but soon. We have had really great success with this. I mean, we had a lot of stumbling blocks, but, unlike PrEP, this is, and they're 2 different populations. We first met, I had one of the first patients who rolled on it. It was really, really exciting for this patient. She has wanted to be on an injectable forever because she did not want to have to take a pill every single day. She lives with family members who are unaware, and she was always so fearful. So she has wanted this, and she was my absolute first patient. And we have grown in our sort of implementation of this and bringing it into our clinic now that we have this really tremendous flow that we go through. And, we're putting more and more and more patients on this, and it's really become exciting. So I will say, I think, again, I mentioned it earlier on, just a reminder, making sure you're aware of anyone who may have implants. You don't want to inject into an implant and cause a leak. But it's important, and I also encourage you, if you are someone who is using or have different protocols, these should be shared around. I hear from many people that they can't implement this in their clinic. They don't have flow, and it's really good to share your sort of best practices. Cristina, I don't know if you want to add anything before we move on.
Yeah, no, I was thinking something that you said yesterday about a patient that has a BMI, very, very high BMI. And so this is even if I know the data that you have presented are very reassuring, because it's not just one risk factor that affects the efficacy of the drug. But I have to say that BMI is something that scares me even more than the genotype for a certain way. So could you tell us about?
Yeah, sure. No, I have a patient who is very, very interested in the injectable for many reasons, a lot of drug-drug interactions. And she's on a drug now. She's on a combination that involves rilpivirine, and I'm very nervous. Her BMI is in the mid-50s. And so I'm very, very nervous for many reasons. One, I think you want to make sure you have the right size needle. So, it's again, things we probably don't even think about in clinic, because other than, I try to think, what things are we giving shots, maybe Depo-Provera, ceftriaxone, but, now we're doing a lot more and C-track technique. And I was trying to think of her body and the amount of adipose tissue. And I was so afraid. And I'm like, we need at least a 3-inch needle here, because the amount of adipose, you would basically be injected the adipose. So we have not started the process yet. We're really struggling. Like you said, I'm very worried about this BMI. And it was one of the factors that was associated. And, and I'm just pulling, but, maybe if we're not going to get this all into the muscle, there goes your other factor, because you maybe will not have an adequate rilpivirine trough. I don't know, I'm making this up, but I agree. It's very, very worrisome. So, again, these are the logistical issues that really need to be talked about. For example, we're looking for 3-inch needles, and not every place has them. And someone said, well, 1.5 inches. And I said, absolutely not. Not even 2 inches. I would never consider that in this person, because you're totally going to inject into adipose. So these are the things that you need to process through when you're coming up with your workflows.
Yeah, I have to say that the other problem that we have, for example, in Italy, is that drugs could be delivered only at the hospital. And something that is of concern is about an eventual I hope that there will not, but an eventual new COVID wave, that could affect negatively all the venues. So it's a little bit challenging, I think. So that's why we are already preparing ourselves and setting the things in order to, receive the patient, have an electronic agenda in order to have them on appointment. As you said, everyone has to find this way to put the injectables in his routine.
I want to finish up with novel therapy for heavily treatment experienced patients. I want to remind you to please feel free to type your questions in when I finish up the last couple of slides, so that way we can address any of them. Yesterday we had a great series of questions, and we were happy to stay over to it because they were such amazing questions. So please feel free to type while I'm finishing these up. So just a reminder, when you're selecting a new regimen for treatment experienced patients, and I think this applies to all treatment, there's some very basic principles that, even though you think you may know, it's really important to hear over and over again. But when you're looking at or doing a drug resistance test, it's important to remember that resistance testing should be done while the patient is receiving the failing regimen. Because if you've stopped the drug and it's been 2-3 months, the possibility that resistance mutation is there, the resistance mutation may have actually gone away and you reverted back to wild type. It's very different when you compare it to transmitted resistance, which we see in naive patients. So the general rule of thumb is you want to test within 4 weeks of therapy discontinuation. Kind of after that, it's sort of really think about what are you going to gain from this. And if you get a genotype back with no mutations, but this person is very, very treatment experienced and has multi-drug resistance, do you really trust that genotype? When you're constructing a new regimen should at least contain 2 fully active agents and at least one of them having a high barrier to resistance. If you don't have that high barrier to resistance, so for some reason you can't use dolutegravir or bictegravir, or you can't use a boosted protease inhibitor, then you want to have 3 fully active agents to include. And then when we talk about fully active agents, it's really uncompromised activity for the patient's history and the results of resistance testing that you have. And I just want to remind you, I won't take you through this, but there are other novel drugs, but just remember there's fostemsavir and ibalizumab. There are 2 different other novel therapies with different mechanisms. They both work on entry. One's dosed orally, fostemsavir, and ibalizumab is an IV infusion every 2 weeks. And again, you can see what they're approved for. And again, both of them heavily treatment experienced adults with multi-drug resistant HIV. And again, always remember, I'm sure everyone knows, but this in combination with your best optimized background regimen, because again, you want to limit, especially if you have limited options, you really want to try to limit the development of resistance. But I think before we end, I'm going to cover quickly. So we talked earlier about the CALIBRATE study, which was looking at the capsid inhibitor, Lenacapavir. And now we're going to look at Capella, which is Lenacapavir in people with multi-drug resistant HIV. And so this is ongoing 2-cohort phase 2-3 trial. You can see the study design here. So these are patients with detectable viral loads, and they have resistance to more than 2 agents from 3 of the 4 main classes, and then less than 2 fully active agents from 4 main classes as well. So 72 patients. They had repeat viral loaded screening, and then based on that, whether you had a decline from screening or more than 400 or a decline of greater than 0.5 or less than 400 is determined which cohort you went into. So here you went into the randomized cohort, and again, you can see what happened there. So you basically, for 14 days, got functional monotherapy. So here you got oral lenacapavir plus your failing regimen, and then here you got placebo plus the failing regimen for 14 days, and then you went on to the maintenance phase, which was either subcutaneous lenacapavir for 6 months for 52 weeks plus your optimized background, or here you did oral lenacapavir for 14 days, followed by the subcutaneous injection plus your background. Then there was a non-randomized cohort that basically got loaded with oral lenacapavir in your OBR, then switched to the every 6-month injection. All the dosing is listed down here. And again, I don't want to bore you by reading doses, but just keep in mind that, when you're dosing, there's certain dose days you dose, what days and how much you get, and then the actual injection. So the primary endpoint was achieved in a prior analysis where there was a greater than 0.5 log decline in viral load at day 14 in the randomized cohort, which is what you want to see when you're giving a novel treatment. You want to see that you're adding something to that failing regimen. And then again, secondary endpoint of a virus load less than 50, less than 200 at week 26 and 52 in the randomized cohort. And so here we are. This is looking at week 26 and 52. And again, what you see here in blue is having a virus load less than 50, and red is less than 200. You can see the virologic failure, no virologic data, and the same thing over here for week 52. And if you look to the right, I think this is really important, and sort of another take-home point is that when you looked at efficacy according to the active agents and the optimized background, as the number of fully active agents increased, so you went from 0 to 1 to more than 2, your response rate, defined as having a virus load less than 50, increased. So, but even here with 0 active agents, look, your viral load was still 67%, with 179, and then 94 if you had more than 2. So really showing how well this drug actually worked. When you look at other outcomes, resistance did occur in 4 patients through week 26, but there was none after that. All had no fully active agents in the optimized background, leading many to conclude or wonder does this drug have a lower genetic barrier to resistance? I think Christine covered that really well in the CALIBRATE study. You had mean change in your CD4 cell was 83 cell increase. And again, remember, these are patients who are really multi-drug resistant. The incidence of a very low count, CD4 count, meaning less than 50 cells, decreased from 22% at baseline to 3% at week 52. And then the increase was sort of just the opposite. You went from 25% at baseline to 60% at week 52. Again, as you would suspect, injection site reactions were most common. Most were grades 1 or 2. 2 patients actually had a grade 3 injection site reaction. Anyone that had a nodule was a grade 1, except 1 patient with 2A of grade 2 nodules after the second and third injection. And they both resolved within 3 days. 1 patient discontinued due to the ISR. And then, as we mentioned, these trials are on hold, compatibility with the vials. I want to finish up before we take questions and sort of wrap this up for both Cristina and myself. So I think we started out a discussion talking about pre-exposure prophylaxis, and long-acting injectable CAB was now approved for every 2 months. We did show that breakthrough infections have occurred but are rare, and then delay in diagnoses that were seen in clinical trials could be mitigated with sort of the addition of HIV RNA testing to your sort of management of these patients. As initial therapy, subcutaneous lenacapavir in combination with oral therapy was efficacious compared to oral ART. And then as a switch strategy, using long-acting cabotegravir and rilpivirine is available now for every 1 month, every 2 months, and I might throw in with or without oral lead-in. There have been a small number of treatment failures despite on-time dosing, and numerically more were seen with the Q-month dosing. And finally, in heavily treatment-experienced patients, remember lenacapavir subcutaneously was effective when combined with an optimized background. And I will say, regardless of the number of active agents, there was a response that was seen. I think that is it, and we're happy to take any questions you may have, and we apologize for running over, but I think there's some really interesting topics here that we covered today.
I'll ask you something, Bill.
Oh, yeah.
We are talking about these new long-acting that at the beginning seems to be the perfect answer to low adherence. But actually, the genetic barrier is not perfect for any of them. So what do you think? Do you think that they are good candidates for low adherent or not?
Yeah, no, these are great questions. I think, the way I look at it as, here's another option. So I have plenty of patients. I practice in Philadelphia. I have plenty of patients who, for many, many reasons, are unable to share their diagnosis with family members, friends, and they live with other individuals. So the idea for them of not bringing home a medication is so important. I always wonder when someone comes in and their viral loads are up, and why are you not taking the medication? We go through everything that we've learned to do for 20 years. And a lot of it is around stigma. So I struggle, because you're right. I mean, what if we get this and we now develop prophylaxis mutations or whatever, so I agree with you as well. But my thought, at least for where I practice, is, for some patients, this may be the answer, that they never have to take a pill with them and they never have to walk in with a bottle. I could write a book on some of the things my patients have told me they do. They stand outside the pharmacy, break the bottle, pour the pills in their pocket, they pour it in a bottle, they pour it in, everything you can imagine, because they don't want to go home with the bottle that says the name of the drug. So I struggle, and I guess we'll see over time. It's very challenging for a lot of patients.
Yeah. We have a question by Angela that says, in the setting of PrEP, but I would say also of treatment, desired by a patient on dialysis, how do you feel about offering Cabotegravir for this patient? Actually, I don't think that we have data on patient on long-acting in dialysis. So at least I haven't seen them. So it's very complicated to give an answer. I think that his desire for now is not so possible, I think. What do you think, Bill?
I'm afraid to say. But no, I actually called the company when this came up, and there was no restriction on use of dialysis. You're right, it's not studied. But, the question I had is, there was no reason to think that you would not be able to use it because they're not renally cleared. That was the answer I got when I called. And this was more for treatment.
No. So if you call them, so either for PrEP or for treatment, so no problem. No. So this is good to know. And I think that they should underline this information, share this information much more, because in clinical practice, this is the first long-acting. And so I think that everybody would be worried about, a decrease in protection along the time. So it's important to this.
I think that's the problem with clinical trials. There are so many inclusion and exclusion criteria, which are not how we practice in the field, right? In the field, we don't say to someone, you're on dialysis, I can't treat you. You have end-stage liver disease, I can't treat you. And so the clinical trials are they don't answer all the questions we have in the real world. And that's where, you need to supplement this with real world experience, observational data.
I completely agree.
As well as pragmatic trials. They're important registrational trials, but, I look at the registrational trials sometimes and I'm like, this is not the patient population I treat. I'm not going to go on to harp on a horse about
they are all blonde, blue eyes. They are perfect, while in our clinical practice is very rarely like this. And so it's really something. So waiting in Europe to have long-acting, at least in Italy, because I know that in Germany and UK, they are already available because they have a different regulation. But because in order to have real-world data, we have to have the drug. So there's no other way. So we wait for it. And I think that considering the price, it will be difficult to have Cabotegravir long-acting now in the national health systems since the comparator is the generic TDF-FTC. I give the floor to Jessica for the wrap-up, and I thank you all for your attention, and thank you, Bill. It has been a pleasure
It's been a pleasure.
to be with you in this program. So, Jessica.
Thank you to Drs. Mussini and Short, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.